Hello and welcome. Today we're doing a quick clinical update on diverticular disease, and this is specifically designed to give you the latest, most practical, evidence-based answers for those questions you get at the pharmacy counter all the time.
All right, let's just jump right in with a scenario that I'm sure sounds familiar. A patient comes to you, they've just been diagnosed with a pretty straightforward case of diverticulitis, and they're asking about their antibiotic. For years, that was the absolute standard of care. But is it anymore? Well, stick around because we are going to get to the bottom of that. So here's our game plan for today. We'll start by making sure we're all on the same page with the disease itself. Then we'll cover some super important lifestyle advice, bust a myth I'm sure you've heard, and then we'll tackle that huge antibiotic debate. We'll take a quick peek at other therapies, and then wrap it all up with the key things you need to know for your practice. Let's do it.
Okay, first things first. We have to get the language right. Understanding the difference between diverticulosis and diverticuloitis is, well, it's everything. It completely changes how we manage the condition and how we talk to our patients about it.
So let's break it down. Diverticulosis is simply the presence of these little pouches, or diverticula, in the colon. And it is incredibly common. We're talking up to half of all people over the age of 60 have it, and the vast majority have absolutely no idea. It only becomes diverticular disease when those pouches actually start causing problems and symptoms. That's the real dividing line. And this slide really lays out the whole progression beautifully. You see, you can go from being totally asymptomatic to having what we call symptomatic uncomplicated diverticular disease, or SUD, all the way to acute diverticulitis, which can be simple or, much more complicated. Now, for us in a community pharmacy setting, we're mostly going to be dealing with patients in those middle two categories. Okay, so now we get to where we, as pharmacists, can have a huge impact: counseling. Because honestly, before we even think about prescription pads, lifestyle is the absolute first line of defense here. And the great thing is, we have some really solid evidence to back up these points. We're not just vaguely saying, eat more fiber. We can actually tell our patients that studies show getting at least 25 grams a day can lower their risk of diverticulitis by about 13%. And the same goes for things like vigorous exercise, maintaining a healthy weight, and especially quitting smoking, which is a huge risk factor for nasty complications.
All right, it is time to tackle one of the most stubborn myths in all of GI medicine. This is a fantastic counseling pearl that's going to give your patients some real, immediate value.
We've all heard this one, right? For decades, the thinking was that a tiny little popcorn kernel or a sesame seed could get stuck in one of those pouches and, boom, trigger an attack of diverticulitis. So many of your patients have probably been avoiding these really healthy foods for years, maybe decades, because of this old advice. Well, here it is, plain and simple. Myth busted. This idea is completely outdated. A massive study, we're talking over 47,000 people, found absolutely no connection between eating nuts, corn, or popcorn and getting diverticulitis. So you can and you should confidently tell your patients to go ahead and enjoy those foods. It's such an empowering piece of advice to give. And now we come to the biggest change in practice. Honestly, if you only take one thing away from this whole explainer, this is probably it. The way we think about antibiotics for uncomplicated diverticulitis has totally changed. The entire paradigm has shifted. See, we used to think of diverticulitis as mainly an infection, which, makes antibiotics the obvious choice. But what we understand now is that it's primarily an inflammatory process. It's not always an infection. And that change in understanding, well, it's a real game changer for treatment. And this isn't just a theory. We have the receipts. Two huge landmark trials, the AVOD and Diabolo trials, looked at this head-on. They compared giving antibiotics versus just supportive care and observation in patients with proven uncomplicated diverticulitis. And the results? They were crystal clear. The antibiotics made zero difference in how fast people recovered, their risk of complications, or if it came back, even when they followed these patients for over a decade. So what's the bottom line for your practice? Well, all the major guidelines are now on the same page. We do not give antibiotics to every single person. Instead, we use them selectively. They're reserved for patients who are clearly sick, high fevers, a lot of pain, or for people who are immunosuppressed or have other serious medical conditions. For most otherwise healthy patients with a mild case, observation is now the standard. So if we're not always using antibiotics, what about other medications?
Let's do a really quick rundown of the evidence for a few other therapies you might see prescribed for this. This table really sums it all up nicely. For managing those ongoing grumbling symptoms of SUD, things like mesalamine and rifaximin, maybe even probiotics, they might help some people feel better. But, and this is a really important counseling point, when it comes to preventing another full-blown attack, mesalamine has been shown in big trials to just not work. So we do not recommend it for prevention. Okay, let's pull all of this together. Think of this as your quick and easy checklist for the next time a patient has questions about diverticular disease. Here it is, your cheat sheet. Number 1, make sure the patient understands the difference between OSIS and itis. 2, hammer home those big 4 lifestyle changes: fiber, exercise, weight, and no smoking. 3, be the hero who tells them they can eat popcorn again. 4, be ready to explain why antibiotics aren't always needed anymore. And 5, clarify that while mesalamine might help symptoms, it doesn't prevent future attacks. And let's end with this question. This whole shift away from routine antibiotics just goes to show how fast the evidence can change right under our feet. As we learn more and more about the gut microbiome and its role in all this, what do you think the next long-held belief is that we're going to prove wrong? It's something to think about. Thanks so much for tuning in.